So good morning or good afternoon, everybody. Welcome to the fourth and final learning session for our Diabetes in Special and Vulnerable Population Learning Collaborative. Today's session is part of our Diabetes Continuum of Care Evolving Roles of Enabling Services Staff in Diabetes Management. In today's seminar, we're going to be focusing on referrals and care coordination. As you know, if you attended any of the previous 3 sessions, this 4-session series is part of the Learning Collaborative that we're all part of the Special Populations Task Force on Diabetes Care. And here you can read our mission statement. And this is one of 4 different groups of seminars that are being sponsored by HRSA and by, we're all part of NTAPs and PCAs to improve diabetes care for patients that we serve. And we do have a website. So if you're interested, you can go to chcdiabetes.org, where we have a lot of resources, including the recordings of the previous webinars in this series. So here's a list of all of the organizations that make up the Special and Vulnerable Populations Task Force. And we are your faculty for this particular series of the 4 sessions on the evolving roles of enabling services. I'm joined today by Albert from AAPHCO, from Cindy from Health Outreach Partners, and Hansel from MHP Salud. And I'm Irene Hilton from the National Network for Oral Health Access, which is the NTAP for all things dental or oral health. So again, just another plug for our website. And if you have any questions after the session about anything that you heard in the session, you can either contact us directly or go to training@chcdiabetes.org. So we just want to do a final introduction, which is if you could just put in the chat, just so we know who's here today, and your name, and then your organization that you're from, and then our question. This is post Valentine's Day. So are you a dark chocolate or a milk chocolate person? I know there's probably somebody that's not a chocolate person, but the people that are chocolate people, are you dark chocolate or milk chocolate? And I will start off by saying that I am a dark chocolate person. So if you could just put that down in the chat, like I said, name, organization, and your chocolate preference. I have to check it. Oh my gosh, it's almost equal. Oh, Albert puts down the actual specific percentage of dark chocolate right on. Okay. Oh, wait.
So did Hansel.
Oh, okay. Okay. 90%, wow. Okay. Good to know. Okay, so this is, like I said, our 4th and final session of the 4 for this particular series, and we're going to be focusing on referrals and care coordination. Actually, I'm wondering if if everybody can mute themselves. Thanks. Thank you. So again, the whole series of 4 sessions was about the evolving roles of enabling service staff in diabetes management. And you heard in our previous sessions about how enabling staff is being used again to look at food security and other community health worker functions, for example. And so in this particular session, we want to focus on the role of enabling service staff, specifically community health workers, on referrals and care coordinations for patients with diabetes. And our learning objectives for today will be to explore how enabling service staff can facilitate clinical referrals within the health center discuss the importance of patient education and patient literacy about the referrals that are being made, and learn from our special guests today about how One Health Center's referral and care coordination workflows, how they've implemented this in their own health center. So we've shown this slide pretty much in every one of our sessions about, again, the roles of enabling service staff in diabetes management. And today, we're going to be concentrating on two roles here on the left side, which is case management, care coordination, is a piece of case management. And again, on referral, because many times patients with diabetes need other referrals, and they could be internal if you provide those specialty and higher level services or ancillary services in the health center, or it could be outside of the health center if you don't. And this could be if the health center provides it either through contracting or just a referral arrangement. But again, the role of enabling services staff to facilitate, again, this process and provide whole person care. So we just wanted to spend a little bit of a couple of minutes before we hear from our special guest health center to think about, again, clinical, we'll split it the two pieces, the clinical referral and care coordination for patients with diabetes. And the reason that this is important is because clinically we know that the side effects or the outcomes of long-term diabetes has a lot of clinical implications, as providers. And these are just some of the different areas, and places in our bodies where having the general, condition of having diabetes can have specific impacts. Again, the eyes with, diabetic retinopathy, the teeth and the gums with chronic gum disease and loss of teeth, issues with the heart and kidneys. Many patients, may end up in dialysis, and skin issues and sex organs, of course, the foot problems, foot sores, bladder. So although we try, our first goal, of course, is always preventing, adverse outcomes and conditions in these areas, in these systems. If it does turn out that our patients tend to develop or get to a certain level of disease, they may need referrals to any one of these specialists, again, optometrists, ophthalmologists, dentists, hygienists, cardiologists, nephrologists for dialysis, podiatrists, all of these. And we may or may not have, may have some of these available in our health centers, but others we may not. So again, here's opportunities to think of, again, in a system of whole person care, how do we arrange and ensure that our patients that have or need these referrals are able to access them. Then there's also, again, for our patients with diabetes, thinking about whole person care, there's the complementary side, which is the social determinants of health. And again, there's a connection, the intersection between the social determinants of health, which could be impacting people's diabetes status, and what we'll call clinical, is behavioral, the intersection of all of those things. So again, our patients with diabetes may need, referrals, whether it's within the health center or in the community, to agencies and organizations that, again, provide food support. And we heard that in last week's session, but healthy eating in terms of classes and education, smoking cessation, physical activity support, certainly behavioral health, which most people get in the health center, but others may need referrals to external, and then legal assistance, housing assistance. So again, we're using enabling services staff to also facilitate and ensure these types of the referrals for these kinds of needs. So there's a lot of things, like I said, to provide whole person care, both clinically and non-clinically. And again, they're all interrelated, where our enabling staff can really provide a service to our patients. So just a little bit about what is a successful referral, because to go beyond the checkoff box, if the primary care provider, whoever, has this list of services and referrals that patients need, and they check off like 5 different things. What constitutes a successful referral? Presumably it's if the patient actually attends and receives the services or the support that they need. And again, the role of the enabling staff or community health worker is more than just, maybe could be just more than actually making an appointment or linking a patient or a particular client to a particular service, because a lot of the success depends on whether or not patients have an understanding or literacy about why it's important for them to attend those appointments. Like if a provider does do a referral for a nephrology consult, but it may be an hour away, you know, and so and if the patient maybe doesn't feel like they're having any issues right now, they may decide that they don't need to go, you know. So again, there's also an educational component, again, depending on the individual patient, that could be in play in order to assure successful referrals for, you know, all these different services. And then again, for each health center, looking at diabetes management of the patients, you know, it's the in-house referrals versus external referrals, and making sure that you have resources identified if you're going to do external referrals. Again, looking at cost of referrals, is it going to be subsidized, or do you have an arrangement? You know, is it contracting so that it's going to be covered by PPS, let's say if it's a Medicaid client, and then also the acceptability of referrals to patients. So again, language congruency, use of translators, transportation assistance, all these other functions of enabling service staff that are brought in, can be brought into creating an environment for successful referrals. So the referrals, again, the referral is just like one piece of it. The care coordination, this is like the definition of care coordination, you know, straight from the internet or, you know, whoever. You know, again, deliberate organization, actually this is the Institute of Medicine definition, deliberate organization of patient care activities between one or more participants, which includes the patient, that are involved in patient's care to appropriately deliver the services. So again, addressing gaps. So again, it's the patient, it could be patient's family or other extended people involved in their care team. Again, the care team at the health center, the providers, and the patient themselves, to help facilitate and again, provide what is needed for the patient to be able to take advantage of this referral opportunity in order to, you know, again, improve their care and their outcomes and achieve optimal health. So, this is interesting. I'm not sure how this slide got here. Okay, this is supposed to be at the end, so we'll pretend we don't see this. Oh, wait. Do we have, uh-oh, we're having a technical issue. Okay. Okay, at this moment, I'm supposed to transition to our special guest, but we seem to have lost that PowerPoint. Okay, let's go back. Let me stop the share.
Olivia, can you enter the law firm?
Okay, let's stop the
Enter
share.
the law firm.
And let me find.
I have the link for you, Irene, in the chat box. You can click on that one.
Oh, okay.
Hopefully that works. And Jennifer has the backup in case that doesn't work.
Okay, let's see. That is so funny. Okay, here it is. Yay. Okay. Woo, that was close. It wouldn't be a Zoom webinar if there wasn't some interesting technical issue, would it? Okay. Thank goodness. All right, order has been restored in the universe. Okay, now I would like to introduce today's special guest. From Northwest Michigan Health Services, Inc., we're going to introduce our guest speaker, Dana Kalinsky. Oh, actually, Hansel, oh, thanks for muting yourself. Dana Kalinsky, a community health worker, Madison Smith, a community health worker, and Jennifer Kearns, a registered dental hygienist and a dental outreach coordinator, who will be talking about the systems that they have set up at Northwest Michigan Health Services for doing referrals for their patients with diabetes, with a special focus on dental referrals, both from primary care to dental, but also from dental to primary care. So ladies, just let me know when you would like me to forward the slide, and feel free to unmute. Let me.
Thank you for the introduction. So yeah, I'm going to start off by talking to you guys a little bit about referrals and care coordination, and also our clinic as a whole. All right, next slide, please. Thank you. So this is our clinic in Traverse City, Michigan. I'm not sure if you are familiar with Traverse City or with Michigan's geography, but it's like in a northern part of the Lower Peninsula of Michigan. And our mission statement here at Northwest Michigan Health Services is that we are dedicated to providing quality health care through a wide range of health services to the people in our communities, always serving with dignity and compassion. Next slide, please. Thank you. And as you can see here, we do have 5 different locations actually. Madison, Jennifer, and I are all primarily based out of the Traverse City Clinic, which is our northernmost clinic. And last year, between all 5 of these, we served over 7,500 patients and provided close to 30,000 medical, dental, and behavioral health visits. At our clinic, we do have medical, dental, and behavioral health all under one roof. So that's a really nice thing that we can offer all of our patients here. Next slide, please. Alrighty, so this is a picture of the Traverse City CHWs and the dental clinic staff. So briefly, I'll go over what Dana and I do. We are community health workers, and we are part of the enabling services team here. And so our job is mainly twofold. One is to decrease barriers that our patients are facing, and then the second is really to help them navigate healthcare. We do this in a variety of different locations. Part of our job is to go out into the community and meet our patients where they're at, wherever that may be. Another part of our job is to do in-house, and a lot of this is integration, and so that's mainly what we'll be talking about today. Next slide, please. Alrighty, so how do we integrate? A lot of this is done through referrals. So if we have a provider on the dental or medical side who notices that, you know, a patient might be missing a lot of appointments because they have difficulty with transportation, or they indicate that they currently don't have housing, they'll send us a referral, and we'll either call, or if we can, ideally we'll integrate with them in person. And this is just kind of what a referral might look like. All right, next slide. And if we're not there, all of our dental providers have this guide here. So each year we actually call pretty much all of the nonprofits in like the whole 5-county region and ask if they're willing to be on this resource guide. And we ask like what kinds of things that we can include, like what services they provide, contact information, and then we create this guide. And so if neither of our enabling service members are in office, we give this to our patients who have indicated maybe financial need or difficulty with food. Ideally, our enabling services members are there to do a warm handoff and kind of explain this guide to patients and highlight some things that are the most useful, because it can be kind of overwhelming for our patients. But it's a great option, especially if nobody's in office, for them to have right away. And next slide, please. And then this is an example of our letter of request for help. So this is something that we could generate in the event that a dental provider had referred a patient over to one of us and said, hey, this individual might need a crown or some sort of work that their insurance won't cover, or something that's going to be a little bit more expensive that they need help covering the cost of. So in that case, a referral would be sent over to Madison or myself or another member of the enabling services team, just kind of requesting that we talk to the patient about this and talk to them about their situation and help them get access to the funds they need in order to take care of their dental work. So after we get that referral, we would talk to the patient to see what their specific situation is. And beyond that, we would be able to generate a letter of request outlining the costs of all of the different procedures that they would need, and a brief description of the treatment plan, as well as highlighting what the individual would need to cover out of cost. This is something that we can then bring to community resources here in Traverse City. We like to talk to places like Father Fred and things like that, just general community resources, and send this over to see if they're able to help out with this in any way. And then beyond doing that, if there was a community resource that was able to help them out with the funding for their dental work, then there could be a letter of intent to pay that would be sent over to our clinic. And then we would know that we can start scheduling the patient for the procedures that they need because it's going to be covered. And then if there's any additional help that they need along with that, such as coordination between our clinic and the resource that's going to be able to help fund that, then we can help with that as well. Next slide, please.
Okay, so now we're into diabetes and oral health. So in my field, being a dental hygienist, I work out in a mobile dental van. So I travel around through our 7 counties treating patients remotely. And then we also have patients in the clinic that I work with. So what we look at as a dental provider is diabetes and oral health go hand in hand. And what that means is we will never be able to get a diabetic patient's A1C number under control if we do not fix the infection and inflammation that's in their mouth, and vice versa. So if a diabetic patient comes in and their mouth is not healthy, which means they have bleeding gums, they have periodontal disease, they have active decay, then we are not going to get that A1C number under control either. And then if someone is going to their medical provider consistently not able to control their diabetic numbers, sorry, my light just went out in my office. Then if they can't control the A1C numbers, then the medical provider sends them over to us in dental so that we can clean their teeth, get them out of any active infection that's going on, and then that helps improve the patient's A1C number. So more than half of the patients with diabetes do have periodontal disease or gum disease in some sort of fashion. And most of them don't know it. So oftentimes the other situation we see is when someone is not improving with their oral health, then we can do an A1C and check their risk level and see why we're struggling with that and send them over to medical to get some help for pre-diabetes or if they are diabetic. Next slide. So in dental, we do have a workflow. So we're going to go through a couple of pieces of information that we do have chair side. So when we talk about the chart, we're talking about a diabetic chart that will screen a patient for low, moderate, or high risk. So we hand that to the patient when they sit down in the dental chair. They read through the list while we are taking their blood pressure, and we identify them as low, moderate, or high risk for having diabetes if they are undiagnosed. So first we identify them with risk. We consider obesity one of our risk factors, family history, and high blood pressure as risk factors in addition to that chart. So that, along with some patient education, we talk to all of our patients about diabetes when they're in the dental chair. When we screen them using that chart, we can do an A1C in dental. There is a billable code for a dental provider to get reimbursed for doing an A1C, and the code is the D0411. Our dental providers aren't currently doing A1C tests in our dental side of our building. Just because we do have medical in the building, we prefer to save time and send them over there. So your dental provider could do the A1C in the chair and bill for it, or we could use the chart, which is what we typically do, is the little chart that you're going to see in a moment. So based on the chart, if they're moderate risk or higher, we send them over to medical for consultation and get started on that side. Also for high risk, if we did do the A1C in our clinic, we use 9 as our cutoff. So if they are higher than 9, obviously they're going to need some immediate help. If they're lower than 9 or close to 9, we still like to send them over to medical because obviously we want to try and get them closer down to 7. But right now our cutoff is 9. If they are currently diabetic, if they are controlled, we do encourage them to continue being controlled by maintaining their dental visits every 3 to 6 months, as well as taking exercise classes to stay healthy. If they are uncontrolled, we refer them to our medical side, or if they have their own medical provider that's not with our organization, we send them back to their physician. We do encourage the education classes and some of the exercise classes, and we do some handouts too before they leave. And then if they are not diagnosed, we definitely send them over to medical if they don't have a primary care physician. Our local hospitals often have free exercise classes and other classes in their diabetes department, so we collaborate with them for our patients. Next slide. So here's one of our flyers. You can see we have a Spanish speaking one and an English speaking one. They are infographics. A lot of our patients do not have a reading level higher than 3rd grade, so we find the infographics are very helpful. Next slide. And then here's the charts that we use chair side. So the old one is the red, yellow, and green one. The newer one is the teal one. And I'm sorry, they're not very legible, but you can get them online and you can just download copies and then use them. We laminate one to keep in the dental chair so that patients can use that, and then we can wipe it off when they're done for the next patient. Next slide. And then this is how medical refers to us. So it's not exactly in a chart form, but you can see that the medical providers do go through a little flow of their own. And in there, kind of towards the bottom, you can see that they ask if they've had a dental visit or not. If they have not had a dental visit, we make sure that they do get an appointment in dentals to try and make sure that they don't have any oral infections, and we get them up to health that way to help control their diabetes. Next slide. So here's another slide of our jelly bean. So we use eClinicalWorks for our dental software, medical software. Everyone in our organization uses the same software. So what happens is when a patient is in the dental chair and we identify them at being at risk for diabetes, then we can do a jelly bean to the medical side, and we can do a jelly bean to the CHWs. So what we write in here, for example, it says that this person is struggling with transportation, they can't keep their appointments, they also need some education, and they need some transportation help to get to those appointments that they need to make. So the CHWs will take this information, it's in the chart, so all of the patient information is already there in front of them when they open up this jelly bean. And then every conversation they have and interaction with the patient gets listed there at the bottom with a timestamp, so we can track the work that's going on. So whether they give them education, information, they send them for some classes, if they send them back to their primary care physician, or they did get an appointment on the medical side, all of these things would be helpful to write down in there and timestamp, so any one of us can go back in and follow up with the patient and make sure that the patient's on track. Our CHWs can enroll people in the food prescription program. That's very helpful. We do have a student coming from Notre Dame in June, and we're hoping to have a large project to improve our integration. So we do have some work to do. COVID kind of separated us a little bit in our building with COVID protocols, but we are getting back on track. And in June, we'll have our student coming from Notre Dame, and hopefully she'll be working on a better protocol to integrate the CHWs in with medical and dental. So our warm handoff is a little bit more smooth. But right now the CHWs are invited into the operatories to speak with the patients. If we don't have time for that, or the CHW is not in the building, we do use those 5-page resource guides. We give those to patients, and then we send a jelly bean to the CHW to follow up with them later. But if they are in the building, then they can take them right there and take that process over and relieve the medical and dental providers to go back to seeing their regular schedule of patients. I think that's it. Next slide. And here's our contact information if you guys have any questions for us.
Actually, I have a question.
Yeah.
let me, okay, I'm gonna be dangerous and stop the share. Okay. I have a couple of questions for y'all. Just, and if anybody has any questions, you could please chat them in or even just unmute yourself. But I have two questions. And the first one is about the dental, because it's actually, at least in our experience, it's rare that the dental department, dental clinic has as free open access to community health workers as you do in your health center. So can you talk a little bit about who started that? How did that happen? I mean, whose idea was that?
Yes.
You know, and how have you been able to like implement that? You know, like what do you have to do to make that like work?
So Dana and Madison, feel free to chime in here. But it started with some funding originally. So I believe it was a grant that we received to try a CHW. And after we had them for a while, and even though the grant ended, we decided to keep them on, and that was a board decision. So we are an FQHC. So our funding is through the HRSA grant and then other small grants that we get and things like that. But we did decide that it was worth it, even though, you know, it's not a moneymaker, it does help significantly. So whether they're helping patients get to the appointments to keep our schedules full so we don't have so many no-shows, or they help patients just improve their lives overall and be more successful in life. Both of those things have such a huge value that you can't put a price tag on. So we do not specifically have funding for them right now, but we did work it in. Dana and Madison, do you know any more about your funding? I know Madison is an AmeriCorps volunteer, so that's a little bit different having Madison.
Yeah, I was just going to touch on that. So yeah, I'm an AmeriCorps volunteer. So if there's any way your health center can get those, it's like a really great way to get basically free help. I work through Michigan Primary Care Association. It's kind of like an advocacy group, and they are the ones that hired on all these AmeriCorps workers to serve at different federally qualified health centers across the whole state. So yeah, that's a great way to try to get a CHW if your state has that option.
And then I'm not sure where funding for my role comes from. I think it is just like Jen said, and it's kind of like a built-in role for the clinic now. So
yep, so we have a CHW at each one of our clinics. We actually have a school-based health center in a high school, and that clinic is medical and behavioral health. They do not have dental there. We drive the van over there to provide dental, but they do have a CHW on staff in the school through our clinic. So we do have one of those as well.
And Dana and Madison, the second question is, do you also do, you provide these services for all, not just dental clients, right, but also other, so can you talk a little bit about at Northwest Michigan, like in terms of facilitating care coordination and referrals for patients with diabetes to these, how much of what you do is actually internal within the clinic versus external referrals, let's say to whatever specialty care patients with diabetes may need that you're working on?
So we just got a nurse care manager, so that actually helped a lot. So now I think a lot more of it's internal and less of it's going to be with us as CHWs because she's an RN and she has a little bit more expertise. But definitely, especially with diabetes, a lot of it is external. We don't do too much like nutrition coaching and stuff, although many CHWs do, and they kind of become like experts at that and trained in that. But our clinic has chosen for our roles to be more about like overcoming barriers and stuff rather than being a nutrition coach or something like that.
Mm-hmm. Okay.
There is a question about transportation help. We do the SDOH. You want to talk about the prepare form and the PHQ-9?
Yeah. So what we do is like every year as a patient comes in, they have to fill out a prepare form, and on that form they can identify if they have had barriers to transportation that have prevented them from getting to their appointments, or if they have experienced difficulty in the past year with accessing things like food or clothing. And at the top of that form, it does say that someone might reach out to you about the answers that you put down. And so that's something that Madison and I do a lot in our role is we get the prepares sent over to us and then we're able to reach out to patients. We do this primarily on paper in our clinic. Some other clinics use an iPad and it can be done electronically, but in the Traverse City Clinic, we do paper mostly. So that results in Madison and I following up with these patients if someone had indicated that they've had trouble getting access to medicine or healthcare in the past year. We can go into their file and see if they might be eligible for Medicaid, and then that can be something we contact them about and try to get them signed up for.
Yeah, so that's our standardized way that we get notified. And of course, the other main way is through referrals from providers.
It's really nice to have them sitting near the checkout at the front desk. So when you're walking your patient out, you can grab one of them and say, hey, can you have a conversation real quick? So we kind of bombard Dana and Madison all day long with just handing over random patients if they're sitting there. So as long as they don't have their headphones on, we know they're not talking. We just give them people. But it's super helpful because it does keep your providers on track, which it's so hard as a provider to talk to your patients about all of those really important life issues that are barriers to them becoming healthier. So you can't keep, drilling and filling teeth all day long and the same person keeps coming back with new cavities or late to their appointments. And we got to stop somewhere and reset the wheel. So that's what we love having Dana and Madison here for.
Well, it totally makes sense. Like I said, the fact that people are able to access, like I said, the note that you put in about transportation issues. Again, it doesn't just have to come from, everything has to come from primary care or behavioral, and dental services also is a piece of whole person care. So what
Sorry, Irene, we've also found that I think patients tell Dana and Madison a lot more things than they tell us too. Because when they sit down in our dental chair, we go through everything with their updated health and their history and everything that's going on in their life. We update that, but it never fails when they get back with Dana and Madison. They always learn way more about their personal life and ways to help them than we ever did.
Sorry about that. I keep touching my mouse, okay, and moving things forward. We go screen sharing. Okay, I have a note from Albert saying we want to launch a quick poll before we go into breakouts. Okay, so I guess that means there's a quick poll. Okay, so actually there's a quick poll about the session, and then we're just about to go into breakouts, and then we're going to have Madison and Dana and Jennifer split between the two breakouts, so that we can we're curious to find out or have everybody share how you currently use your enabling staff, and it could be health workers or it could be other physicians, to support internal and external referrals for diabetes. So just if everybody could share, like I said, what your own best practices and how you've set up your system. Here we have one great example from North Michigan of how they're using community health workers to do their external and internal diabetes referrals.